Thank you, good evening and welcome to this special edition of Q&A. I'm Tony Jones. Tonight we're focusing on death and the dilemmas we all must face. Here to answer your questions, writer and doctor Karen Hitchcock, who believes we should be helping the elderly to live well. Journalist and broadcaster Andrew Denton, who used the Wheeler Centre's die-gribble argument to make the case for voluntary assisted dying. Anna Lamaro, who's living with advanced cancer and hoping for a conscious and peaceful death. Ralph McConaughey, the head of the palliative care unit at Brisbane's Wesley Hospital, and Victorian Dr Rodney Syme, who for 25 years has been helping terminally ill patients who want to end their lives. Please welcome our panel. Thank you very much. Now, we have been inundated with very strong questions from the audience. Let's go straight to the first one. It's from Rose Cox.
Hi, my mum has a rare neurological disease similar to multiple sclerosis. She has no control of her bowel or bladder. She can't walk and she's very limited use of her arms. Although she can't move, she does have feeling in her body and does experience chronic pain. Although my sister and I take care of her, she still enjoys her life. However, her disease is degenerative. Mum has been very honest and open with us, and we know that there'll probably be a stage where she doesn't want to suffer anymore. If we don't have a law to allow my mum to request an assisted death, then what do my sister and I do if it reaches a stage where she asks for our help? Andrew
Denton.
Well, Rose, that's a doozy of an opening question. Thank you very much. Unfortunately, in Australia, because we have no law for assisted death, you have very, very limited options. You have to put her into the medical care system, and you know, we have a brilliant palliative care system which will do her best, do its best for her. But the options they offer, you know, she'll get full care, both psychologically, spiritually, physically. She will be assisted to lead the best possible life she can, but towards the end of her life, the options she's offered are few, and it's terminal sedation, which is to be put in a coma until she dies, or it's something which, in my 8 months exploring this issue, truly shocked me about the reality of dying in Australia today, which is this, that palliative care believe that it is ethically acceptable for a patient to choose to hasten their death by refusing treatment, including food and water, and starving and dehydrating until they die, which can take weeks and which I'm told is psychologically painful for the people who die and for those watching. But it is ethically unacceptable for a patient to hasten their death by taking a medicine, such as they prescribe overseas, which will kill them quickly and painlessly. I find that an appalling situation, but that is the reality for your mum in Australia today. The choices facing her are limited.
Andrew, before we come to the other panellists, and you've raised a bunch of issues there that some of which will be canvassed in further questions, but for 8 months you examined this issue, you investigated it, you went overseas and looked at the options in Belgium, in the Netherlands, and in the United States, in Oregon. So what did you come up with? What sort of legal solution do you propose?
The law I propose is a mix of what I've found in the States and in Europe. What I've taken from Oregon is what's called voluntary assisted dying, which is where you are prescribed a medicine by a doctor if you meet certain criteria, which you and only you can take. It's entirely voluntary, and that's very important to remember, because very often you're going to hear people say someone has been killed. It is you that takes it. From Belgium and the Netherlands, I've taken the idea that the entry point to this is what's called unbearable and untreatable suffering, and that's a recognition of the fact that that can come in many guises, not just the main diseases that these laws address, which is cancer and heart failure, but it can be diseases like Rose's, it can be motor neurone disease, it can be a stroke, it can even be chronic rheumatoid arthritis. It can come in many ways. To access this, the very core of it is you have to be a competent adult. If you're not a competent adult, nothing else happens. You have to convince 2 doctors, independent of each other, that your suffering is unbearable and untreatable. All treatment options have to be discussed with you. You have to make an application both orally and in writing, not once, but twice. You have to be offered mandatory palliative or hospice care as part of your treatment. If all these are agreed between you and your doctors, and the 2 doctors independent of each other, without the family involved in these consultations, I might add, so that there is no possibility of coercion from family members, then you can be granted the right to end your life, and then a prescription will be written for you for the medicine which only you can take. If the doctors at any point think that there are psychological reasons driving your request, then they can bring a psychiatrist in to consult.
Okay, now Rose's mum, Caroline's sitting here listening to this. I'm going to bring you in a minute, Caroline. First, I want to hear from the other panellists. Karen, what do you think? It's the dilemma facing the daughters who wonder what will happen if their mum is not in a position to make those decisions for herself, to take those actions for herself.
Yeah. I guess from my perspective, life is never the problem to be treated. Life is not the illness or the disease that we want to treat. What we want to treat are your symptoms, your physical suffering, your need for care, your mental anguish, and those would be the things that I would hope that we could help you with as you reach the end of your life.
Let me come to Rodney Syme on the end here. What should Rose and her sister do, in your opinion, if their mum's illness reaches the stage where she can't do things for herself?
Well, frankly, I don't think it's a decision for her daughters. This is an entirely decision for her. And I think it's fantastic that she is having this conversation with her children, so that as a result of this communication, this dialogue that is going on, they will sort out the issues. They will sort out what are the sticking points. Where is the stage in this illness where I think I would be hitting a brick wall? I don't know the actual diagnosis. It sounds like a motor neuron type.
Transverse myelitis.
Transverse myelitis. Okay. Well, I think there's one big advantage in that. It's you're not going to be challenged with a respiratory problem as people are in motor neuron disease. So it will be the progression of paralysis. I don't think that's an ascending condition. It's at a level and it affects your limbs. Your arms are all right? Yeah. So this is a condition which it would be possible for someone to live with for a long time if they have the support that is necessary. But you've also got to take into account not just the physical symptoms in a situation like this. There can be very severe psychological and existential suffering. There are a lot of losses apart from the physical losses that can occur here. The inability to do the things that bring joy in life, the inability perhaps to be creative, although with your hands you can still be creative. But the key thing is to have a dialogue with not only the family but with your doctors, so that everybody knows what the ground plan is, how far can we go, if somebody hits the brick wall, that they can be guaranteed assistance.
Rodney, let's go to Caroline. You've been patiently sitting there listening to other people discussing your life. It must be quite frustrating in some respects.
That's the key, isn't it? Everyone's discussing my life.
Yeah,
my life and my choice.
Yeah, so tell us about the discussions you're having with your daughters.
Well, they know that at some point in my life when things become intolerable and the pain becomes intolerable as I age, then I don't want to stick around beyond that point. And I don't think it's really up to anybody else what I do with my life, just the way I've run my whole life. I think I should be able to choose that end. There's no legal framework. There's no way of getting a medicine, as Andrew suggests, to take. That's the point.
And you listen to Andrew's proposal there. Is that something you think governments should look at?
I think we should have legislation that that gives us the opportunity to choose our own end when things become unbearable, the pain becomes unbearable.
Let me go to Ralph Mahoney. You're a palliative care specialist. Listening to this, what are your thoughts?
Well, I think it's really difficult and a very, very hard situation for you, Caroline, and your family. And I guess, having heard what the others have said, I think the really compassionate, valid points have been made all the way. I suppose what I can add to that is simply that I think in this process you need a relationship with someone in medicine. You know, be that a really close and supportive GP, palliative care specialist, your neurologist, but I would hope in the course of your illness you meet someone from the field of medicine I practice in. And what they need to do is work with you. That they're not someone you see in crisis, they're not someone you see in distress. There's someone who knows you, who understands what you feel and what you need, who recognises your intrinsic value and the dignity you possess despite the loss of function that you have. And I should say, I think dignity is not measured by how your body works. It's what's in here and what's up here. And that's what we need to embrace. Part of that, I think, is to realise you do have control. I think the danger in modern medicine is that you can be a cardboard box on a conveyor belt. You turn up at emergency and before you know it, you're in intensive care having stuff done to you never wanted. There are things that happen, and I'm sure probably have already happened in the course of your illness, where your life can be in danger. And it's perfectly all right to say, thanks for the heads up, let's not do anything about it. There are times, I think, in all these prolonged degenerative diseases where doors open and it's all right to step through. I don't see any ethical reason whatsoever that we should be saying, no, you know, you keep living for a bit longer. It is your choice. And with what Rodney said, I think we share a lot of common ground. I think the difference is that perhaps it doesn't need to be done in the specific way that Andrew suggested, but simply a discussion with the people who care about you in medicine. And if it is, you know, an infection or some other thing that happens, we can keep you comfortable, but we can allow that to run its course and life to draw to a close without the need to resort to euthanasia per se. But it still gives you control, it still gives you a very strong say in what happens, and you remain in charge. We're just passengers on the bus with you.
I'm quickly going to go back to Carolyn. Is that, as spelled out by a palliative care specialist, does that have an appeal, or do you...
To be able to choose not to have treatment and let things run its course, I don't see why you've got to suffer weeks or days. Why, if you don't want to run its course, then you take a medicine and that's that. Simple as that. Why do you have to run a course of infection?
Thanks, Caroline. I'll go to Anna Lamaro. You've got a daughter yourself. What do you think about the dilemma facing Caroline's daughters?
I think it's an incredibly difficult situation, as Ralph has said. And whenever I've heard similar case studies in the whole euthanasia or voluntary assisted dying debate, which has been going on for over a decade now, whenever I've heard these case studies, my heart goes out to the person suffering and wishes only that their suffering could be relieved. It is a very, very deep and profoundly complex decision to make in a profoundly complex setting. So I think that it is an extraordinarily difficult thing for you and your family to be undergoing. And personally, while I would not wish to stand in the way of someone exercising freedom of choice, my whole life has been lived according to the principle of individual choice, well-informed choice. Personally, it's not a choice that I'm imagining that I would take, but my circumstances are different, and every situation of serious illness is different, has its own characteristics, has its own particular challenges, and I'm presuming that I know enough about what might be ahead of me for that never to have occurred to me as an option, but it's not an option that I reject or feel that others should not be free to choose if that is their individual choice.
Can I just ask, Anna, I think you've made an advanced care plan, but what do you actually face? What is the extent of your illness? What are the doctors telling you?
Well, as is often said, my cancer is at the 4th stage, and it's frequently quipped that there is no 5th stage. So things are serious. I have a spread of my cancer to a vital organ, and so I don't find it useful to seek opinions about how long do we have. I don't find that a very useful concept or piece of knowledge to have. So certainly I'm facing, anticipating an earlier than expected death at the age of 62. So that is the reality. And the advanced care plan, there's a problem in regards to legislation with advanced care plans also. You can state what your wishes are and have them legally constructed and delivered to your treating doctors and so on, but they are not necessarily followed. There's no legislation to guarantee that my advanced care plan also will be abided by. And that's also a concern. So, and my choice is basically not to foreshorten my life, but also not to extend it beyond the point by taking any dramatic or heroic measures. Even, resuscitation or antibiotics are things that I've written out of my advanced care plan. I don't wish to continue on in a state that might become more and more complicated and difficult to abide.
Thanks, Anna, for setting that out for us. Now, our next question comes from Luke Formosa.
Hello. In the Netherlands last year, a former supporter and Euthanasia Review Committee member for 9 years, Professor Theo Boer, changed his mind on euthanasia, saying it has gone too far, with the number of deaths doubling in the last 6 years. Euthanasia was introduced as the last option for the terminally ill. It is now extended to include mental illnesses, such as depression and even tired of life. It's becoming almost a lifestyle choice. Findings from the Netherlands Euthanasia report in 2014 indicate over 1,000 patients were killed and it was unreported. 550 newborn babies with diseases or disabilities were killed. 41 patients were killed with psychological illnesses. So psychologists have been helping patients with mental disorders make a rational decision to kill themselves. My question is, how do you propose Australia's euthanasia laws would protect the most vulnerable people when the examples in the Netherlands and the Belgium are showing the exact opposite?
Andrew.
Well, you've raised a whole bunch of things there. First of all, Theo Boer, yes, he was on the review committees for 9 years, but he is also, even before he joined them, a sceptic about assisted dying. And when I first heard him talk, and he said 1 in 25 deaths in the Netherlands are now euthanasia, I thought, oh, well, that sounds like a lot. And then I eventually worked it out. That means 96% of people are not affected by these laws. He talks about a 15% rise in euthanasia deaths as though this is an indication of something that's out of control. But then you realise the context of that the number of people that die in these laws, under these laws in the Netherlands every year is less than 4% of all people who die, and that the rise in those numbers is because, like ours, this is an ageing population, and a lot of these are reflected in cancer deaths. I completely dispute and question your assertion that 550 babies have been killed. It's, under Dutch law, there's a thing called the Groningen Protocol, which sounds very sinister, but which in fact applies to very, very rare conditions of extreme spina bifida and a thing called EB, where your skin is literally flaking off, and it has applied to maybe a dozen babies. So I don't know where you got that figure of 550 from, but I think it's not correct. The other point you made about doctors in the Netherlands and Belgium killing patients. This is one of the first things I heard when I started on this journey, and I was very confronted by it. I was told that doctors were killing elderly patients in these countries. And it took me a long time to dig to the bottom of it and find out what it was. And what it was, and Ralph would know plenty about this, is it was in many ways standard palliative care practice. What in fact happened with these so-called murders is, because death is a very complicated thing and there are many grey areas, what they discovered, because the Dutch, unlike our country, have an incredible X-ray over their end-of-life practices. They know exactly what's happened, who's done it, and how it's happened. We don't have that here. What they discovered was that these 1,000 patients who had been murdered, that in fact they were euthanized without their consent. Why? Because they were in their last 24 or 48 hours of their life. They were in a coma. Most of them had had a previous conversation with their physician about euthanasia. If not, the family was there. And more than that, they discovered when they really examined this that the physician had given the medication which had ended this person's life not with the intention of ending their life, but with the intention of relieving their pain. So you just gave a textbook example of what I've been dealing with for 8 months, which is conflation, distortion, and frankly, misrepresentation of facts to paint a picture which actually is not true.
Okay, our questioner, Luke Formosa, has his hand back up. You get a chance to respond to that.
Yes, no, I completely disagree with a lot of what you've said too. So the euthanasia rate in the Netherlands in the last 6 years has almost doubled, from about 2,500 to about 5,300. They reckon there's at least 1,000 on top of that that was unreported. and the babies being euthanized as well. That is also in the report. It's in the 2014 euthanasia report and also a 2010 report as well. So, but besides from that, I completely disagree with your assumption that there's no people slipping through the cracks in Belgium and the Netherlands. It is very apparent on the internet when you look at reports and papers, even academics, professors. There's a report that's been released in the medical journal Bioethics this year, and it specifies over 1,000 people in Belgium that were euthanized without consent. Over 50% were over the age of 80.
OK, Luke, I'm going to get you to come quickly to your point.
OK, 2/3 of these didn't even have terminal illnesses. Also, you have a 24-year-old woman in June this year who's been granted the right to die because she has had suicidal thoughts in Belgium. So there are people that are getting the right to die for cases which are not terminal illness, not extreme pain, and sometimes it's almost like these people just need somebody to talk to and some people to encourage them and love them, and it just seems like it's, in the Netherlands and the Belgium, it is definitely a case for the slippery slope.
OK.
If I can quickly answer that. Again, Luke, I totally dispute your assertion about babies, and if you're going to the internet as your source, then that might explain why you've come up with that figure. But I would remind you of the core things about this law, which is it is voluntary. You have to be an adult who is compos mentis, who understands what they're talking about, and that the point about what you're saying about that you're fundamentally misunderstanding when you say, oh, it's psychiatric, it's this, it's that. As I explained to you, the basis of this law is unbearable and untreatable suffering. It was never just about terminal illnesses, and that is actually the thing that makes this law so compassionate and humane. It is an understanding that suffering comes in many different forms. So what you are, the picture you're painting and what you're asserting is a very deliberate misrepresentation of what is actually happening in these countries. And what I found was a very compassionate and rational and very well thought through and carefully scrutinised system. And if you want to look at what's happened in that system and find out, I'd love to see you prove those 550 babies, you'll have no trouble finding it out because there is no system more documented anywhere in the world than those in Belgium and Netherlands about end-of-life practices. Who did what, how and to who. So
right.
Go and look at those.
OK, we'll stop that confrontation just for a moment because we've got another question. It's quite a challenging one as well. It's from Joan Hume.
Every day, people like me with quadriplegia and similar disabilities are told we're better off dead and that we're a burden, particularly on the health system. Now, the medical community, and here I'm talking about doctors and nurses as well as allied health professionals, has encouraged families not to have or to raise children with disabilities. Today, some still participate in enforced sterilisation of children and young women with disabilities. This is happening in Australia, and frequently make arbitrary, autonomous decisions not to resuscitate us in unrelated illnesses like pneumonia. My question to the panel then is how then, if medically assisted suicide is legalised, can doctors be trusted to value our lives equally to those of non-disabled people?
Let's start with the Dr. Karen Hitchcock.
Thanks for the question. I really do think it's a risk. I totally agree with you. I think that if we decide as a society that we can kill people rather than care for them, then that normalises that decision in a way. And although we highly value autonomy in this society, and we think that people make choices freely and that we're all strong, self-willed, highly educated. But there are people in our society who rely on the care of the state and rely on the care of others, and I think that that those people are vulnerable to unspoken coercion. And if they feel like a burden, if they're made to feel like a burden, they're not a functioning economic unit anymore in our society or economy or whatever it is we live in anymore, then I think that they can suffer coercion in that way.
Andrew, I know that when you began this journey, your first stop actually was an anti-euthanasia convention. You were surprised, I think, to find quite a few people with disabilities there.
Yes.
Listening to this question, is that reflected in what you heard there?
Absolutely. In fact, I spent a fabulous afternoon at Joan's place talking to her. Hello, Joan. And we talked about this quite a lot. And before I respond to that, I'd just like to again remind people that we're not talking about killing. This is voluntary. We're talking about people taking a medication themselves. It is an entirely voluntary act. And I'm going to correct it every time I hear it because it's an entirely different thing. Joan...
I'd just like to say something, actually. You know, if we lived in a society where the elderly, the frail and the disabled actually did have choice, like the choice of where they live, the choice of the kind of care they get, full support, if we were really generous as a society and maximised people's feeling of worth and able to have meaning in their life, then I would say, yes, it's completely voluntary. But we're talking about people who don't have choices that, like, we do with our able bodies humming around and our
So you're suggesting
secure
that,
lives.
that somehow or other disabled people are more easy to coerce than able-bodied people? Is that what you're saying?
No, I'm not saying that. I'm saying that they have less choices, and that if as a society we do not, at the moment, even though we're such a rich country, we don't offer adequate care, then their choices are limited. And if they feel like burdens, then they're more likely to choose not to live.
Well, let me go. Andrew, can I pose this to you as a question? What's the evidence show in the countries where they do have doctor-assisted...
It's very interesting because I was told that the disabled and the elderly were vulnerable under these laws, and I went there, and everywhere I went, this is what I looked for. Now, not only could I find no evidence of it within the system, and I've yet to see any credible evidence that the disabled are in any way coerced or vulnerable, I did something that I don't believe has been done before. And Joan, you know this, because when I told you, you actually went very quiet and said, can you please send me their information? I went to the representatives of the peak disability and elderly groups in Belgium, Netherlands and Oregon, not people who have skin in the game when it comes to euthanasia or assisted dying. Their only interest is in representing people like Joan and the elderly. And I put to them all the things that have been put to me about what was happening to these communities, that they were being made vulnerable, that they were being coerced, that they were somehow lesser people, that they were economically disposable units. And one by one, they said to me emphatically, no, 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 we have no problems. We have no problems under these laws. These safeguards work. And in fact, Bob Junedef from Disability Rights Oregon said to me they had received only one complaint in the 17 years that law has been running, and it was from a quadriplegic person who was concerned that the laws discriminated against them because they couldn't take the medication. So I understand your fears, Joan, and you made it very clear to me. Your fears are very real, but it doesn't make them a reality. And my view is that you don't have to believe me, but as I said to you on the day when we spoke, you should go and speak to the people that have the same lived experience as you under these laws and ask them how they find them, because they don't have a problem.
I'll just quickly find if Joan wants to respond to that.
Well, we've tried to search out some of those contacts you gave me, Andrew, and all of their information was in Dutch, and unfortunately I don't speak Dutch, so I wasn't able to pursue that one, but I was able to pursue a little bit the information on Bob Dundorf, and I have been advised that that is an organisation of that represents not so much people with disabilities, because Disabled People's International is the peak international body. That is more like a legal kind of centre where they deal with legal issues related to disability. We've got a similar sort of organisation here called, I think, the Disability Rights Legal Centre. So they're not necessarily people with disabilities. They
are the go-to people in Oregon, however, and that was the state where it was relevant.
OK, I'm just going to quickly hear from... sorry to interrupt you, Joan. I want to hear from Ralph. Now, in your time, you've overseen, I think it's 5,000 deaths, effectively. Do you think there's a genuine concern here that Joan and other people who have lived with disabilities have, that if the laws change?
No, I think if they run well, not that I'm supporting them, but I think if they run well, those protections should be there. I think the difficulty, and Andrew's been very thorough in this, is, has enough time passed? And is 10 years, is 15 years enough to say this isn't the way this process will go? over the next decade or the decade thereafter. So it's possible to build those protections in.
But also, Ralph, if I may, I mean, that's a reasonable question, but you have to look at the trend. And if the trend tells you that it's stayed stable all this time, what would make you think that is suddenly going to change? And particularly in a country where we've just come through the most rancorous decade in Australian politics, and the one shining light of bipartisan agreement was the National Disability Insurance Scheme. So the theory I hear from some within the disability community that somehow or other in this country, once this law comes in, that the political, social and medical community are going to turn their backs on the disabled community who for some reason are going to be coerced into dying under these laws with all their safeguards seems very unlikely to me.
It's not that extreme.
It's not that aspect to it though, but there are other things that can provide that coercion where people are interested in money, for instance, health insurance companies, hospitalisation, the cost of providing good high quality care to people who need it. That's where the subtle pressure may come from.
Sure, but that's where the idea of two independent doctors, independent of each other, who, by the way, their actions and their decisions have to be reviewed.
Surely.
It is their job to pick up this coercion, and that's why you speak to these doctors away from family members, away from other people. It has to be a genuine, persistent request where you have to convince doctors of why you want it to happen.
But also, if in that situation, they also have a sense that that person is suffering and genuinely wish to end their life, that's drawn out of a lack of resources and a lack of support, are they then going to say, let's not provide euthanasia here, let's take this situation to bat to the organisations that are making life difficult for these people?
Okay, so I'm going to interrupt both of you for a moment
do,
because we've got another question that is a different perspective on this. We're watching a special edition of Q&A. We're talking tonight about the end-of-life choices, including voluntary assisted dying and euthanasia. If you or someone you know finds tonight's discussion disturbing and you need urgent help, please call one of the numbers on your screen. Well, the next question is a video. It's from Laurie Daniel in Canimbla, New South Wales.
I have progressive multiple sclerosis, which has concentrated my mind on the subject of end-of-life choices. I've learned that it is not illegal to end your own life in Australia, but bizarrely, it is illegal to receive medical assistance to do so and to end your own life in the company of people who care about you. Why do Australian laws force some 2,500 of our friends, relatives and loved ones every year to end their own lives in the slowest, most painful, sometimes violent and loneliest ways imaginable?
Rodney Syme, let me start you off here.
Well, that question raises the whole spectrum of neurological disease, which is one of the most difficult things, I think Ralph will agree with me, to provide palliation. You can't palliate paralysis. You can't palliate the loss of function of bowel and bladder. It's extremely difficult to palliate the psychological and existential suffering which accompanies this. For example, motor neurone disease, a progressive disease which robs a person of the use of their legs and arms, gradually then coming up to affect their ability to speak, to swallow, and ultimately to breathe. And there is no palliation which you can give for this disease. You can support the person with physical aids and nursing care, but ultimately this is a slow, tragic death. And I have to say that whenever anybody suffering from motor neurone disease contacts me and wants to discuss the end of life, I listen to them incredibly intently. I have found one of the most important things in the work that I've done is that with a person like this, if you give them control over the end of their life, you are giving them one of the most important palliative tools that they can possibly have. Because now, instead of suffering from that oppressive psychological and existential suffering, they know where they're going. It's bloody hell every inch of the way, but they know they've got the key to the fire escape.
So, yeah, tell us what the key to the fire escape is from your point of view, Rodney, because you've been known to give Nembutal to people in these circumstances.
There is no doubt that the drug of choice is Nembutal. People are helped to die, and in the Netherlands you find a lot of papers in which people are helped to die with opioids. In my view, that is not what is called euthanasia. That is almost certainly pain relief. Opioids are a very poor way to hasten somebody's death. There is just...
But Rodney, I'm going to interrupt you here because what you're talking about is plainly illegal. There are people who hear what you're saying, who will argue not that you're just hastening someone's death or giving them an exit key, but that you're actually committing a crime.
Well, I would debate that. I've openly gone and stated to the police that I have given a man, Steve Guest, Nembutal. I've described the circumstances in which that happened. At the end of the day, the policeman said to me very kindly, I don't think there's enough evidence to prosecute. I've had policemen come into my home after I'd given medication to a woman. And she had, as I'd suggested she did, she had a discussion about the matter of her wanting to end her life with her family because she hadn't done it. I think it's absolutely imperative that a person who wants to end their life engages with their family, gets them to understand why they need to consider making a decision like this, gets them involved in the process, the humane process of dying. In that instance, the woman who took the medication had told her son that I had given the medication. As a result, a coroner's inquest took place. The police came round to see me, and as they walked down the door to interview me, they said, "Don't get alarmed, doctor. This is just for a coronial inquest, not for a prosecution." I would argue, just as...
Can I just put it to you like this? Are you actually trying to provoke the police to prosecute you?
Yes,
so you
indeed.
can actually have a test case?
Yes, indeed. Because I would argue that what I am doing in providing somebody with medication is providing them with very, very good palliation. If Ralph can help a person to die by providing them with injectable medications, morphine and midazolam, providing them with an injectable process which hastens their death, and he's doing it to relieve their suffering, then I argue that I can produce and provide a person with medication which provides them with palliation, relieves the psychological and existential suffering which they have when they're facing a dreadful death, then I believe that that is a palliative act.
All right, you've brought Ralph into it here. Ralph, is that effectively, you've essentially been, the suggestion is that that's what palliative care ultimately does with terminal sedation, I imagine.
Well, I think there's a whole lot of things that we need to realise in this discussion, really, is that the vast majority of people die dignified, peaceful, comfortable deaths, if you can use that word, in the presence of their family, having drawn their life to a close in a way that's most satisfactory for them. And we're talking about 98% of predictable deaths in this country. So the debate we're having about euthanizing individuals is to a very small percentage of the population. The vast majority of people have dignity, have control, and die in the manner that they would have hoped to see happen.
Yes, Ralph, but that small percentage, it's only 2 to 3% in
Surely.
the Netherlands, it's a similar percentage, it's even less in Oregon. Are these people to be disregarded and disrespected?
Okay, I'm going to bring in a questioner. I'm going to bring in a questioner who is right on that topic. Sally Crossing.
I have a terminal illness, metastatic breast cancer. It can be held off for a while, but there's no cure. While I'm well enough, I want to make sure that my dying will be the way I want it to be, not decided by anyone else. Not doctors, priests, palliative care teams, no matter how well-intentioned. I want the supreme comfort of knowing my life can be ended if and when I decide enough is enough. And I'd like to be able to seek some professional help, as I do for other decisions. I respect the rights of other people who do not seek this comfort, but not their attempt to prevent me from making my own life and death decision choices. Can anyone put a cogent argument as to why I should be denied this choice?
I know, if you don't mind, I'll start with you on this. I think we're going through similar things. I'd be interested to hear what your perspective is on this question.
Certainly. And Sally, I wouldn't stand in the way of another individual's choice, such as you're proposing. My own perspective on it is that I have, and possibly you have too, from the sort of description of your journey through this that you've just made, accessed a lot of therapies, a lot of professional help. Very, very many of those have been psychologically based, because I feel that that is a very important avenue for exploration when one is facing death, and also with the issues that arise while one is living with a serious illness. So my perspective is that, and the reason that I describe that my wish is for a peaceful death rather than one where I actively choose the moment to end my life, the reason that I emphasise the peaceful death is because this block of time, 4.5 years now, since more or less since my diagnosis, I have consciously attempted to address the issues that I think might have predisposed me to become ill, and that those sorts of issues which might trouble me on my deathbed had I not addressed them. I'm a little unusual case in the sense that there's no history of breast cancer in my family. I had none of the predisposing lifestyle factors, in fact quite the opposite. And so I ascribe, apart from the ambient pollutants that we're all exposed to in this industrial society, I ascribe the triggers for my illness as coming from poorly adapted stressors in my life, things that I was unskillful in negotiating at 3 critical points over that period of years leading up to my diagnosis. I see you frowning, so I'll just explain a little more.
Well, perhaps we can come back and ask Sally why she's frowning.
Well, I'm frowning because my question's got nothing to do as to why you or I or anybody else developed breast cancer or prostate cancer or multiple sclerosis or anything else. It's is there a cogent argument as to why somebody who would like to know, would like to have that bottle of Nembutal up in the safe, I suppose, would be the best place for it, probably would never use it, but would have the comfort, the supreme comfort of knowing that if I no longer wanted to continue my life as it was, or as it had become, I could stop it.
I understand why you're making that choice, that safety valve. I interpreted that Tony was asking me why I would make a different choice. So
I did, but I'll go to, and we'll come back to that as well, but I'll go to Karen, because I think you wanted to get involved. Can you offer a cogent reason why Sally should not have that option?
I guess euthanasia to me is not about a right to die. You have a right to die. Dying is not illegal, and I would never want to impinge upon your rights in any way. You certainly have a right to humane care. I guess euthanasia for me is more about the right for the state to sanction organised killing. It's about the right to kill, and I think that is the problem with euthanasia.
Karen, may I just... you know what I'm going to say about killing, but I don't need to say that again.
No, but if I provide you with a drug to die, then that's what that is. I mean, we use all of these euphemisms.
That is not true killing. That is this lady making her choice. Can I just point out to you something that Eric Willick from the Royal Dutch Medical Society, who, by the way, this was an organisation who admitted honestly to themselves what is happening in this country now, but which our doctors do not wish to admit, which is that assisted dying happens all the time. And let me finish. And what they said is, this is actually happening. So why don't we put some safeguards around it to protect doctors and patients? And I asked him about the right to die, and he said, there is no right to die. There is no right to death. Death is a fact at the end of life. What there is a right to have a choice about how you might die.
Can I just address one thing?
Briefly, because I want to get to another question.
So I think that the difference between euthanasia and what is happening, for example, in palliative care in Australia today is a difference of intent, and I think it's really important. In palliative care, you do not treat life as the symptom, so you do not give medication with the intent of killing the patient. However, you do give medication to treat the symptoms,
with the intent of the patient killing themselves, yes.
Can I just interrupt you? Can I just interrupt you both? Because I've actually got a question on palliative care, and it's from Richard Chai. We'll go to that quickly. Richard.
Thank you very much. And I'm very pleased that you actually opened up this debate so that we can talk about dying. In terms of killing, if I'm going to write a medication, write a prescription for the medication, even though a patient takes it voluntarily, I'm still killing the patient because I've provided the means. I still have done that. I'm a palliative care physician. Don't bring any religious views to this. 1 in 20 of my patients come with some form of request for euthanasia. And when they get good care, not just palliative care, but just good care, those requests evaporate. And I say they get good care, and I think that's the important thing. So before we even talk about euthanasia, shouldn't we talk about how we can improve palliative care so that everyone gets palliative care for any illness?
Okay, well, I'm going to get Andrew to start us off on this debate because I know that you and Richard are acquainted with each other. Richard actually runs the palliative care unit at St Vincent's Hospital in Sydney.
And I had an amazing week there, and I have nothing but respect for the professionalism and compassion that I met. Look, there's a few things to be said. First of all, I'm a huge supporter of palliative care, and I think it does an incredible service, and the more funding and support it gets is a good thing. If you look at somewhere like Oregon, for example, where almost every patient that is granted the medicine also goes, I think it's more than 90%, goes through palliative care. So these things go hand in hand. Palliative care and the right to die and these medicines go hand in hand. In Belgium, their euthanasia laws came from their palliative care doctors who acknowledged what you know, Richard, and what Palliative Care Australia also knows, and Ralph would know, that there are a percentage of patients who, despite the best efforts, you cannot help. And I met a beautiful man there called Arsène Mouly, who's was the head of palliative care in Flanders, Belgium. And like you, an incredible capacity to care for his patients. But he had a slightly different philosophy. His view was this. He viewed euthanasia as an act of love towards his patient. And what he said to me was, if the patient has reached a point where they are dying and where there is nothing to be done to help them, and they ask for my help, how can I not help them? And he said, and this is the most beautiful philosophy, he said, when someone is suffering, how can I ask them to suffer more? And that is the question I would put back to palliative care, knowing that there is a small percentage, you're right, Ralph, of your patients who are beyond your medical care, which is no slur on you, this is the case around the world. Knowing this, why are you so timid about addressing what it is they're asking for, which is a choice beyond what it is that you can offer them?
Let me ask Ralph to answer that.
Oh, thank you. I guess since I'm the palliative care dude on the panel, we need to talk about a few things. And just from my classmates here, I think there's misconceptions that we should clarify, and part of it is this. I guess going all the way back to an earlier question, for those percentage of people who are suffering, who we have nothing left in the bag, I think there's always something left in the bag. It isn't, though, we say, well, mate, too bad, we've done all we can.
But what if that's not what they want, Ralph?
Yeah,
what if they don't want
appreciate that.
Why should a patient, because Palliative Care Australia acknowledges that there are patients who make persistent and rational requests for a hastened death. So why should a competent adult who is dying, who asks, begs, to be helped to die quickly, be told they have to die slowly?
Well, as was mentioned earlier, I've probably been closely involved with the deaths of more than 5,000 people. Not a recommendation you want from most doctors. And in that setting, and this is the honest truth from my experience, I have yet to be met with an earnest request for euthanasia at the end of life. Now, that's my honest truth in that.
But you acknowledge these people exist.
People exist.
Yeah.
Can I do, we actually have, we've got the husband of one of those people in the audience, John Flynn. Can we, John Flynn's in the middle there. We'll just get a microphone to you, John. And we'll just quickly hear this story and then come back to you.
My wife suffered from a cancer next to her spine. After multiple surgery and experimental drugs, she found the pain was overwhelming for more than 2 years. Then, in the best palliative care and under sedation with opiates, she received no food or water for 14 days to accelerate her death legally. How can starvation and dehydration be the best option to end life?
I think that's a terrible option, and I agree with you. I think that's not humane care for another human being.
Ralph, can I just ask, is that what terminal sedation is? What is it then?
There's several things to that. Let me just quickly talk about the food and the fluid aspect of things. As you advance to the end of a progressive disease, the desire to eat and drink goes away by itself. That's not something people routinely choose to give up. It just quietly goes away because their body is dying. The need for the natural nutrition and fluid intake diminishes. So from that point of view, I'm not condoning what happened in your wife's experience, but the way we talk about people not eating and drinking is very different when you're at the extreme end of a severe disease. Eating and drinking is much, much less occurring than you think. For families who love that person, the way we show we love is to give people food and fluid. We give them what we think is nourishment, but it comes to a point where that is no longer relevant. It really isn't as you approach the end of life. I think the other thing is, need a little drink? When you reach that situation, if there is no other way to provide relief, then I do use terminal sedation for people. I use the same drug, Nembutal, in a diminished dose if it's required. I use propofol, the famous Michael Jackson alternative to living a long life. Those things are our toolbox, but they're applied in a very different way. The goal of that treatment is the absence of suffering. To achieve the absence of suffering, that person needs to be asleep. Now, all the evidence shows when that's properly done, they're as asleep as a general anaesthetic. That person's suffering is at an end. Their physical body is still alive.
Can I just ask, is that not euthanasia?
No, let's look at the difference. If we provide someone with Nembutal, the dose is designed to take a life and the outcome is death. If I provide someone with sedation to relieve suffering, the goal is reached when that person is sedated and suffering ceases.
So what you're supplying is a slow death as opposed to a more rapid death?
Not at all.
In a sense. Because, Ralph, may I ask, for what purpose was John's wife left alive for those extra days? To what purpose?
Several things to that. I think what we do is sedate someone so they're asleep. The disease underneath in that sleeping body progresses.
What if
death
that's not
almost
what they want,
invariably occurs because the disease progression, long before death from dehydration or starvation.
Ralph, can I just hear Rodney Syme on this, because he earlier made the case that terminal sedation is a form of euthanasia, I think. That's what you said.
Well, there have been experts in the field of palliative care, the famous paper by Billings and Block, who described terminal sedation as slow euthanasia. What the hell, Ralph, do you think I'm doing when I provide someone with medication that might end their life? Do you think I'm intending to kill them, or am I intending to relieve their suffering? I think you insult the doctors in the Netherlands and Oregon, not you, but people do insult the doctors in the Netherlands and Belgium by saying these people are killers. That contention has come about because of the way in which the Remelink report has asked the question about voluntary euthanasia, and the question said, was this an action with the intention of ending life? Yes, but if you ask a different question, was your intention to relieve suffering, you would get a huge plus answer to that question. The Dutch doctors provide assistance to die for their patients because they want to relieve their suffering, not because they want to kill them.
And Tony, can I...
Well, you can, but we've got another question. We've got time for one last question tonight, and it comes from Melissa Reader.
Thank you. I have a short story and a slightly broader question, I think. My first husband was diagnosed with stage 4 kidney cancer at the age of 41, and the period of his illness was very, very difficult because of his declining health, but also because of the fact that nobody could talk about his imminent death. Not him, not his family, not his health practitioners, and as his wife and his primary carer, I felt that would be the ultimate betrayal to raise that conversation with him. So what resulted was we never talked about it. We never talked about his hopes, his wishes for his children, what he wanted to have me know, I guess, about the future. He didn't even leave a will. And I think that we could have done that better, and we certainly should have done that better. And I guess my question to the panel is, what do you believe we need as individuals within our families and across our communities to possibly talk about dying more openly.
I'll start with Anna Lamaro here, because your whole concept is to die a good death. What about talking about it in advance?
Indeed, I think that we certainly have a death-phobic society, and that goes against any acceptance and integration of death into the whole fabric of being alive. And I think that if we did have such a process of education and sensitisation to this issue from the earliest of ages, then we would have much more full and deeply appreciated lives, but we also wouldn't have this dread and fear when it comes to the subject of death. You know, the news of a death is often greeted with, "Isn't it awful?" or "It's so unfair," or "How could that happen?" Now, in many cases where the deaths apply to older people who may have particular diseases or whatever, it seems outrageously unrealistic to have such a view. But it is the view because we, as a society, have this pushing away impulse when it comes to death and to dying. And I think that we do ourselves a great disservice. We do an even greater disservice to the person who's going through that process and dying. And you now, Melissa, are left with wondering what you might have wished or thought or hoped, and so on. But whatever was in that man's heart didn't have its opportunity to be explored and discussed and shared. And I think that this is an aspect of care over the whole of the healthcare system throughout our lives, but particularly in the palliative care setting, is that there needs to be much more of that. Now, palliative care is, you know, there are all sorts of things that apply to it. One is that you might be directed to palliative care late. The other is that there are limited services, even with the wonderful palliative care that I know is available from my personal experience. That there needs to be more, there needs to be richer, there needs to be more choice within it so that people have that opportunity to do that exploration. And I think that the awareness that these things are required has sprung up from the community, and it's sprung up from people like Ian Gawler, whose foundation continues to do fantastic work in assisting people to begin to explore these arenas of life that we so patently ignore, and people like Petria King, who does similar work, I believe, in New South Wales. Now, it springs up from the community, from within my own community, the lesbian community in Melbourne. A wonderful book was written back in 2007 called Willing Up and Keeling Over, and it explores the whole range of issues that come up when one is caring for a loved one or a friend who's dying, when one is the carer and going through all the struggles that the carer has, all of the things that are required. Now, the reason I point to this is that it's the community of those experiencing these things, like you, Melissa, who are now aware of what was missing. You're now painfully, no doubt, aware of what could have happened. And so the more we talk about these things, the more we explore these issues, the more we stop our death phobia, then the greater the community can have a richer life, and I hope, for many more, and myself as well, a rich and peaceful death.
Karen, can I hear from you this idea that we have a death phobia? It's one of the serious problems we face as a society.
Well, I think death is pretty terrible. I mean, it's the obliteration of your existence. And
come on, give it a go. It's all right.
It's not like you go to someplace better. But I think that about 5% of the patients on my ward die, and most of them are expected deaths. And I think that what's most important is that we give an opportunity for people to speak about it if they wish. I mean, there are people that are not comfortable talking about death and wish to deny it, and I think that that's okay. We can't insist that people accept they're going to die, but I think it's important that they have an opportunity to talk about it and an opening.
Rodney.
Well, I agree entirely. Communication, to me, is one of the most important principles when we come to talk about end-of-life issues. The communication between the person who's suffering and their family, the communication between them and their medical practitioners. These things are critical to getting an outcome as a good death. We talk about, and I emphasise constantly, people who accept the reality of dying, as you have done. That allows you to go to a good death. You take the elephant out of the room and you talk about it. And you engage as a human being with other human beings about what's going on. And that is the way to get a good death, not by shutting up about it. The fact of the matter is, unfortunately, that our current law puts doctors in fear of entering into GPs, not palliative care people, you do it all the time, but many, many GPs are frightened to death of opening the door to talk with a patient about end-of-life issues because they think they'll be dropping themselves in the deep end. And so the shutter comes down, no, we can't talk about that. And it's tragic. It's tragic.
I'm not sure that it's only that stops them talking. I think that what stops them talking often is that there is this fix-it approach. You know, it's the pathology, let's fix it, we're not allowed to talk about anything else.
Yep.
I have the most caring, compassionate and also excellent communicator in my female oncologist. However, she has made the point several times to me that but what we're doing here is we're analysing blood tests and scans, we're looking at treatment protocols, that's the limit, and that constant shrinkage into that tunnel is what is so diminishing for the person.
We're running out of time rapidly, so I'm going to go to Ralph too, because this is something you do deal with, as Rodney says, every day of your life.
Yep. I think the answer is, much as Rodney said, you have to meet, as a human being, you have to meet another human being who's suffering. You have to offer them care, continuity, support. You have to be honest. You have to speak in words that are understood. You don't have the shadow on the lung. You speak what it is. You let people know and understand where they are. They'll make their choices and they will drive the bus. You are just a passenger. And it's not medicine's job to push people down a pathway. You do have choice, and that's important however you choose to use it, but it's there and available. But having this kind of panel, discussing it and getting it into the community is very important. We have to take away the elephant in the room, as you said, or at least colour it pink so it's more interesting. But it's that process of discussion. Nobody dies because you talk about death. In fact, the evidence is people die better, die more comfortably and live longer if those constructive conversations are had early and continued. Okay. So integrating that into the treatment of your illness, whatever it might be, is paramount to creating a good death and a good life before death occurs. I'm
going to go back to Andrew to finish off, and I'll take you right back to where we began, if I can, because we have a problem here with doctors, but you have a much broader problem with doctors when it comes to your issue.
Yeah,
nice
look,
guys.
I love doctors, and
not too close.
No, I'm always after a doggy bag of pethidine, never get it. But I actually have a great respect for doctors. But what I've discovered in this 8 months I've been looking at this is that there is a reluctance, and I think it comes from the hierarchy of the medical professions in Australia, to truly engage with what's happening in this issue. And as I've listened to this conversation tonight, it struck me, with respect to all involved, that it's been doctors talking about patients. And what I'm not hearing is enough of our medical bodies opening up and listening to what their patients are saying.
Indeed.
And people around this country for 20 years have been screaming for something else. And what I saw in the countries where these laws existed, which is relevant to what you're talking about, is that because doctors can have an honest conversation